I'd like to begin today's webinar by acknowledging the traditional custodians of the land on which we meet today and pay my respects to the elders past and present. I extend that respect to Aboriginal and Torres Strait Islanders people attending today. It gives me great pleasure to introduce to you Mark Silva, who's been a social worker for nearly 40 years in the areas of disability and aged care. Mark brings with him a strong interest in narrative therapies, reminiscence, and storytelling, and brings these approaches to his work in aged care. We have a special webinar tonight, which is to showcase the work that our trainees and students have been doing in residential aged care. As many of you know, the Wellbeing Clinic for older adults has been trying to bring psychological and counselling services to aged care for more than 10 years. And we have discovered a lot of learnings over the years. And Mark is going to moderate a panel to showcase some of the learnings, some of the challenges, and some of the surprises that we have found in our work in aged care. So thank you very much, Mark. I'll let you introduce yourself and your panel to our audience. Thank you.
Look, thanks very, very much, Sunil. And we have the privilege really of opening our webinar series for the year. And we're really very fortunate to have a wonderful panel of students and some of whom have actually transitioned into working as counsellors and psychologists within the field. And so we're going to today share some of those experiences. I'm going to start off introducing a little bit about the clinic and about our approach to work, and then leave it up to really the panel. And we've got with us Philip Wolford, then Sam Houston, then Deb Carveth, and Talia Veschio. And each of them are going to talk about their experiences. I'm actually going to put a difficult task for them to really reflect. A lot of the theme for these webinars is on reflection. We just want to hear from people's experiences firsthand rather than only about the work they do. So without further ado, I'm going to start to introduce the topic, and then one by one, I'll give you some more details about our wonderful panelists. And as Sunil said, we're going to have some time for a panel discussion, and we're going to monitor the chat. So if you've got any comments or questions, please feel free to do that in the chat. So, okay, so let me first of all share my screen. And here we go. So I'm going to talk to you a little bit about what we've termed normative narrative practice. And I'm going to talk a little bit about what that means and why that is a really formative approach. And I think the other thing that we want to highlight is it's the person rather than the problem that we're interested in. And the World Health Organization have defined a wonderful comment. If you ask somebody what's the matter, you're going to get a very specific answer about, they've got a sore toe or they've got something particularly wrong with them. They're going to talk to you about their problem. But if you ask someone what matters to you, you're going to get a different answer. You're going to get an answer which was really fundamental to them and their life. And I think this is where we really want to introduce the approaches, some of the approaches that we've taken. So Sunil's already talked about a welcome to country. It actually should be an acknowledgement of country because I'm not Indigenous, and I really should have changed that to acknowledgement of country. I live in Yakandanda in the Yorta Yorta Nation. The Dudarawa are here, and I think everybody can also take a reflection on where they are actually situated and pay respects to the elders, past, present, and emerging. And I think the honour of the spirit and the memory and the culture that has existed 60,000 years gives us some perspective of the importance of what I later term vertical connections, the connections we have with our roots, which are so important. A little bit about the Wellbeing Clinic. Some of you know it quite well. And it's really emerged about 11 years ago, developed in 2011, really around the fact that emotional needs of people within aged care have been sadly neglected, and there's been really a lack of services, but also a lack of specialised mental health practitioners. And that's basically what happened. Over a cup of coffee, Sunil and I developed this program where we wanted to service not only the residents, but families and staff of people associated with, at that time, residential aged care, because that's one area that has really been neglected, but also provide a training ground, a practicum training ground for initially psychology students, but has also become important to have social work and counselling students as well. So what do? We provided a counselling service for postgraduate students. We have, during COVID, which is amazing, sort of everybody went to telehealth, but we developed a national telehealth counselling support program, which we still have. And that is available to anybody in Australia, not only for residents, but for families and staff as well. We have this webinar series that we've kicked off today. We've also conducted research, and we've done research both in terms of dementia, but also in terms of the people who have depression and anxiety that haven't got significant cognitive impairment as well. And that's quite ambitious. That's coming to an end now. We also have a volunteer program for undergraduates, which is a befriending program, and a digital storytelling program where undergraduates and others as well spend a whole year getting to know a resident, and they do a digital story about their life. We have an intergenerational digital storytelling program, which is a very keen interest of mine, and we've been doing that for about 15 years between school-age children and adults. We have a life story program as well, where we're learning to help through writing, we help people. We have one for carers, and we've had one for illness as well. We've just started piloting, and you'll hear a little bit from Talia about this, a carer support group over telehealth, which has just been happening. And we also are specialising in therapeutically informed group work, which I think is really a specialty in itself. So we developed this outreach model because we realised that moving into residential aged care is obviously stressful, creates a lot of emotional distress for families and residents. There are lots of adjustment issues that have to be addressed. And we all know that there's high levels of loneliness, depression and anxiety faced by people living in those facilities. We also recognise the need for staff to have support. They're in a very time-poor environment, task-oriented, and it's not very easy for them to address emotional issues much as they would like to. We have services that have a lot of gaps in them. You know, if someone has a significant diagnosable mental health issue, they can be directed to the Disability Support Australia with their specific behaviour response service and the behaviour management service or the aged psychiatry team. So, but not very much for people that don't fit into that diagnostic model. So people who really need their emotional well-being addressed. We also have the primary health networks, which are wonderful, and hopefully they'll get refunded when the funding finishes in June this year. But again, their services are limited, and eligibility is limited too, because some of them have limited numbers of sessions, and also they can't really see families or people with dementia. And people may not know, but the changes in the government Better Access for Mental Health scheme not only reduced the sessions from 20 to 10, but it also on the 31st of December stopped that program from going into residential care. And before the Royal Commission reinstated it, it actually wasn't available to people in residential care before December 2020. So that's a real shame. And there's a lot of advocacy trying to change that. So in terms of the client group that we have, we know that the nature of the problems don't really, they don't actually exist verbally within the population. The issues of concern are mainly raised by staff or families and rarely by the person themselves. And the social isolation and withdrawal, depression and anxiety, grief and loss, disenfranchised grief, bereavement, existential pain, relationship issues, family conflict, just simply wanting to go home. And we've learned this, that most people that could benefit from a counselling program do not seek it. Now, that's interesting, isn't it? Because, you know, one of the reasons the government cited in not having the Better Access Scheme continue was that they didn't think people were using it. Now, of course, they were using it because we haven't addressed the reasons why people are loath to enter having counselling, formal counselling with psychologists, social workers. We know that that's the way to go with this, and we're learning a lot. And you'll hear that from our panel, is to address some of the psychological ramps. We know the physical ramps that we have to do with someone in a wheelchair. We know what we need to do in order to have someone access a building, but we're pretty poor in understanding what are some of the psychological ramps to prevent people from actually using services. And a lot of it is stigma, ageism, a feeling of being labelled, and a fear of being blamed for the situation they're in. Basically, as we talk later, these are normal reactions that people have to abnormal situations as well. So we talk about client and person-centered work, and we have language around that. But I think more and more, we really need to focus on relationship-centered work. And I think that's been undervalued, that we need to focus on the relationship between residents and staff and family, and residents and family. So we know the issues for older adults is around purpose and value. There's some meaning in suffering. They need to feel creative, to feel that there's a contribute to society. They feel there's a lack of self-esteem, self-efficacy, that we need to build personhood, trust, identity building, maintaining dignity and integrity. And we don't do very well in terms of end-of-life issues. And one of the other webinars we're going to have is looking at that. And the need also, we're recognizing more and more, not just the links between people, but the links between them and their roots and their values. Reminiscence is very much about linking people to their past lives and their past ways of dealing with issues, which I think is really, really important. There's also loneliness and boredom, depression and anxiety. Again, belonging to a community, belonging somewhere. There's a lack of being able to express love and care, and feeling like a nobody as opposed to being a somebody. And also the increasing need to assist families. And we have this spectrum of a continuation of issues ranging from this loneliness and isolation on the one side through to serious mental health issues and suicide, which is a big factor that we have to address. So our telehealth program has been really, we've just been looking and trying to evaluate it. And really, we're getting a bit of an idea of, I think one of the surprises is that it's doable. I mean, I think, thought that older people wouldn't take to telehealth, phone and video, but you'll see from some of the examples that it is possible. It is possible to do that. And one of our panel, especially Sam, was going to talk about using telehealth as a mode of intervention. So what do? We offer individual support. We do look at end-of-life issues. Groups, reminiscence groups are incredibly powerful to acknowledge someone's story, to bear witness to someone's story is really, really powerful and transformative. Assisting families and staff, we're learning how to assist staff, maximizing links with the community, and also looking at structural, systemic, and cultural action. And I think one of the things that defines this, we're multi-storied people. We're not just defined by our age or by a particular disability, but imagine being a full-grown adult with a whole lot of things, being a farmer, being, volunteer, being a whole lot of things in the community. And all of a sudden, you're reduced to relating to the world with this simple idea: how can I help you, dear? Would you like a cup of tea, dear? Would you like me to adjust your pillow? Would you like to go to the toilet? Can I do anything for you? And reducing someone to that interaction with the world, is an environment where it's really mental health issues grow, whatever they might have been. So we offer supportive counselling. We there's reminiscence and narrative therapy. From some of our panelists, they're going to talk about adaptive CBT, where thoughts, feelings, and sensations really work together with behavioural activation. And I think CBT has been quite effective in terms of adapting to this age group. And Sunil has been, and another person, Deb Coder, who will be talking next fortnight, will be talking about that in a big way. So this comes to this term, normative narrative practice. Now, I think it's really interesting to have this as a framework, because if you think about that as normative as opposed to pathological, that the issues can be usually seen as normal consequences of a person's relationship with their environment. And it involves combating ageism and stigmatization of counselling. And that's important. So we're not just simply saying, it's your problem, you've got something wrong with you, let's help you. A narrative approach is really something that narrative and reminiscence come together, and it's focused on the person's life story, and on reminiscing as a process of focus of interaction, and inviting the person to share their story, where they want to start, and looking for openings if they want to expand on a particular area. And then the amount of people, as all of you will know, that have trauma in their life and have issues they've never discussed with anyone. Once we establish a relationship, it comes to issues they really, really want to talk about and haven't had an opportunity to. We often have the situation where the counsellor has a great rapport with someone, and then they would say, "Oh, look, can I come back next week?" And they say, "Oh, look, I don't need counselling, I'm fine." So I said, "All right, I'll see you later." And he said, "Oh no, please come back because I love talking to you." That relationship between counselling and talking is something we know, but often the clients don't. And so it's about using the relationship, the use of self, and the uniqueness of the sacredness of meeting of two people that'll never happen again. That kind of sacred space that's created between two people that never actually will happen ever again is, I think, really, really important, that magic interaction. So those three elements within a systemic approach are really important, and viewing the facility as a community. So that's very, very important, strengthening a sense of belonging. So that's really a summary of normative narrative practice. These PowerPoint will be available to you as well. This is a bit of a summary of what I've been saying, that you're working really side by side with someone. It's not as an encounter on opposite sides. You're validating people's experience. You'll hear a lot about that, and meeting together as equals, as experts. So there's no power differentiation and lack of judgment, and there's no need to necessarily correct someone, but working together on issues that people face. These are some of the things that people have done in our work, and bearing witness, all those things are really, really important. The tortoise versus the hare approach is important. rather than rushing. And I think I might end there. These are some of the things that, some of the different ways that you can indirectly work with someone through things that matter. You can actually go and approach it through whatever's relevant to them. And it's an ecological, multi-layered approach that we're looking at. So I've got in here some of the different models that you can look at when you get the PowerPoint. Really interesting, because the environment matters, and the way that we construct our residential facilities is really important to learn from all the other ways that people have done it. And there's a couple of videos that we can watch when you get the PowerPoint. So look, I might stop there and introduce Philip Wolford next. Philip is really actually he's been a student of a Master of Counselling, and has secured after his course a position as Emotional Wellbeing Coordinator at Linden. Really, he comes from a background of pastoral care, and he really, on top of the wonderful work he was working in palliative care, he developed a tremendous additional set of skills to build on that. And I think he's had the lived experience with working embedded within a facility, and it'd be lovely to hear from Philip. He's got lovely examples, and I'll introduce a quote that he wanted me to share with you. I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. So Philip, over to you. And you might want to say a bit more about yourself, but we're very, very lucky to have you. And over to you.
Thanks, Mark. You've really sort of introduced me quite well. And certainly I've come from a very, background. And just something, to introduce myself. It's interesting that I'm doing aged care at my stage of life. I'm 70, and in my wildest dreams, I really didn't expect, to be working in the aged care sector at this stage. As Mark said, I was origins in South Australia. I left a farming background to go to university, train for church ministry for 30 years, and then opportunities opened up, some time ago to branch out and work in palliative care. And then in 2020, I decided to reinvent myself and upskill myself in late life by returning to academic, study and doing a master's in Swinburne in 2020. And my student placement was with Swinburne Wellbeing Clinic, providing telehealth counselling and support to services to residents in care. The residents and clients I was working with had a complex array of challenges, significant cognitive, sensory and communication, as well as physical and emotional issues. Now, the significance of what I'm going to say today is that during my placement, I was given a face-to-face referral, the first one that I'd had in about 6-7 months because of COVID, for a resident at Linden Aged Care, Camberwell. And after 2 weeks, the clinical services manager referred me to 6 more clients. And I believe that they appreciated the support and the work that I was doing with these residents. They offered me a position as emotional wellness coordinator. This was an innovation of care at Linden and generally in the residential aged care sector. Now, I've been at Linden now for 18 months in this role. And hopefully during my presentation, you will be able to notice that there are similarities as well as many differences in my role to that of a counsellor or a psychologist coming into on a referral basis or request to a residential care, facility. My slide's not working. Yeah. Something about Linden Aged Care is a standalone community-owned not-for-profit organisation, initially administrated by the Camberwell Council here in Melbourne. And Linden Aged Care offers residential low care and high care to 102 residents and accommodation in 6 independent living units. Linden does not provide specialised dementia or acute care needs, although some residents have escalating high care needs as their health deteriorates. And if you want information about Linden, you have the web link there. Linden has a emotional support policy, and this policy is designed to support residents' emotional well-being to ensure each individual has a feeling of control, purpose, and sense of belonging, and minimise the feelings of loneliness or social isolation. 5 crucial components of this policy is having and maintaining resilience and coping, being protective and contributing, encouraging social connections, ensuring the meeting of individual needs and comfort, and enjoying sensory enrichment. My position as emotional wellness coordinator is to provide psychosocial support, spiritual care and bereavement support to both residents, relatives and staff. And I work very closely with the clinical services manager to provide these support services. The clinical services manager is my line manager, to whom I directly accountable to on a daily basis, associated with the role of emotional wellness. I'm employed 3 days a week and 5 hours per day. Something about the residents is fairly important for you to understand the residents that I work with to get an idea of what I actually do. The demographic, the average age is about 89. The resident age range is 73 to 102, with a very strong big cluster between 90 and 95. And the average resident stay from admission to death is 3.3 years. Working in a residential aged care facility, on staff, you see the decline and death is an inevitable and irreversible process that will happen in any residential aged care. In my 18 months at Linden, I've witnessed the slow or rapid decline of residents' physical and cognitive ability, leading to death. In my time, I've seen and supported families lost loved ones of 24 residents. It's difficult emotionally to witness this decline and then say farewell. And I confess that at times I've had a tear or two. The reality is that these residents come into care, and my role is to ensure that they experience a quality of life and support in their last days. So there's a wide diversity of emotional, social, and clinical needs amongst the residents, as you can imagine. The challenges associated with comorbidity, the complexity, the symptoms and behaviours that are reflective of the range of issues, chronicity, the behaviours that are ingrained by lifelong attitudes and behaviours, and continuity, the residents and attitudes and values fashioned by their time. So where I find residents on a daily continuum will depend upon the wellbeing support and care that is required. Just sort of focus a little bit on comorbidity, because it affects the quality of life of the residents in care, as illustrated by my observation of Linden residents in this slide. These quadrants reflect the diversity of needs and support by an ongoing interdisciplinary team in any residential aged care facility. And you'll see it's quite evenly spread over those 4 quadrants. The next slide reflects the needs that I encounter. and I submit a daily, a monthly report and data to management that helps identify these needs in the care and gives some credibility to my role. And this are the figures and stats for last January, and it'll give you some idea. And I'll just pause a little bit and just let you glance through the type of support and the numbers there that I've counted, and that would be a fairly typical month. As you can see, there's a wide range of issues that come up on a daily, weekly, monthly sort of basis. Concerning referrals and resident contact, because I'm on staff and I actively engage in the ebb and flow of daily challenges, routines and rhythms of the facility and of the residents, my contact with the residents is essentially from spontaneous interactions ranging from 2 to 3 minute encounters and greetings to a more extended in-depth conversation of issues the residents face. And because the emotional needs are varied and often unprompted, I daily choose to prioritize whom I should focus on and support according to their presentation. I appreciate the conversations with the clinical staff who give me updates on residents and verbal referrals. So my role is mainly spontaneous, being in the right place at the right time. And if you ask me to explain what I mean there, I really cannot explain it. It just happens. It's about being seen and being present rather than a clinical referral counselling system that gives everyone the confidence to reach out to me in times of need. It must be said that from my observation that most residents at Linden are living out the last days of their lives, having adjusted to residential care. Yes, residents do experiencing challenging times and down days, but having a person in my role, being present daily in the facility, emotional and well-being issues are quickly attended to. Also, I've learned not to go looking or expecting residents' issues or challenges when they are not there. There can be days when peace and tranquility is bliss, but on other times there is plenty to attend to. So how do I go about my role as an emotional wellness coordinator at Linden? Mark Silva, as my supervisor, used this phrase, whatever it takes, therapy. A garden metaphor is helpful in describing this approach. Walking into the garden, you discover a rose bush that is not thriving. You ask, what does this rose need at this present moment? Does it need water, fertilizer, or pruning? And as a gardener, you make a decision and commit to an action that will restore that rose bush to a thriving display. So in my role, it is first and foremost being present and sensing the opportunity or the moment, utilizing whatever action is needed for the resident. What does this resident need at this present moment? Once the need is determined, I commit intentionally to an activity, not necessarily a therapy application that facilitates well-being. It is essential to point out that contact with residents is not a formal therapy session, but informal to the degree that my time with residents is spontaneous, casual, and momentary. Taking a resident for a walk, holding their hand, or other intentional activity that facilitates well-being is not an end in itself. There is a purpose. The intent is to bring about empowerment, resilience, insight, affirmation, and dignity. It is about making meaning and giving value to that resident. I've also coined the phrase Groundhog Day therapy. It is a contact with residents in ways that have happened before and will happen again in what seems to be exactly the same way. There is not a lot of variation in structure and content with some residents. Many reply upon my prompts, questions, and my retelling of their story to them. Some find it hard to make conversation, and retelling their story allows them to experience the emotions and sensations associated with the story. It is the ability to leave a space for regret and horror and fear and silence, thankfulness, and even celebration. I've used the internet iPad to describe places and events, and the iPad is always, with me wherever I go, to listen to music and to encourage the residents to be stimulated by the present moment. When they cannot remember important detail, I retell their story to them reusing past conversations or images. I want to introduce, Joan to you very quickly. I met Joan in the corridor one day and she made a comment that she had not seen me around. I relied that I'd been on holidays and she asked me where I went and I said Victor Harbor, South Australia. Immediately she came to life. She said, that's where I was born, in Victor Harbor, and spent her early years near the beach. Immediately I got out my iPad and we Googled Victor Harbor and we sat in a room, found the house where she lived. We spent 45 minutes in reminiscence as she shared her reflections of her early years. This was a serendipitous, unplanned moment, bringing some joy and reflection to Joan. It was so significant that Joan had to tell her daughter that she had seen the pictures of where she had grown up. As I reflect on my role, a subtle process has evolved. A relationship is first developed by taking an interest in the resident. And over the months, the conversations deepen and trust built. And when a crisis occurs, the relationship has been established where they feel cared for and supported. My role is laying a culture of care and support so that when issues arise, they have a person they can trust and turn to who's unconditionally present. Thanks. Yeah.
Oh, Philip, that was moving. I had tears in my eyes, and I'm close to getting into care, so can you be my counsellor? And I think there'd be one of you in every facility. It's beautiful, really, and I think it describes the breadth of work and the importance of relationships. And in the 18 months you've been there, you've really built an amazing presence. And thank you very, very much. And we'll hopefully have some questions for you in discussion. Let me introduce Sam. Sam Houston is actually a school counsellor in a very large school, high school in Sydney in the southwest. And as part of her Master of Counselling degree, she completed a placement with us, offering counselling appointments via telehealth to adults living in aged care facilities. She's a very person-centred counsellor who believes that empathy is the greatest therapeutic tool. Her presentation is going to talk about the challenges and benefits really of telehealth in aged care. And she's going to reflect a bit on her experience and discuss the modalities that she found most useful to engage with older adults and share some of the things that she learned in her experience counselling older adults and how it really influences your work today because you're continuing working with the adults. So that'll be interesting to hear. So Sam, over to you, and thank you so much for sharing your experiences. Yeah, I've got to unmute you. I'm sorry.
Okay, thank you.
Thanks, Sam.
Sorry.
No, it's my fault.
Ironic because we're talking about telehealth, so thank you. All of my professional experience, as Mark said, has been working with children and young people. So as part of my master's, can you see that okay, my screen?
Yeah, fine.
Yeah, okay. As part of my Masters of Counselling, I got this opportunity to work with the Swinburne Wellbeing Clinic offering telehealth. And I wondered how my skills might translate across very different age groups. And I was really keen for the challenge. And what I found is many skills do translate. I found this image from The Little World of Liz, and I think it illustrates really nicely person-centered counselling. Really sorry, I've got a bit of hay fever, and of course now is when my eye starts leaking. Person-centered counselling is really, when I work with young people, we talk about separating the person from the behaviour. And when I was working with older adults, we looked at separating the person from the ailment. And I think Mark's talked about this a little bit already, so I won't go into that too much. I found engaging older adults in telehealth that there was a little bit of stigma, like Mark has mentioned, that there was a bit of stigma associated with counselling, and that's not something that everybody was interested in. Oh, sorry. Not something that everybody was interested in, but that having someone to speak to for a period of time was something that they were interested in. And I think even with young people, it is very rare to be able to sit with a person and speak for 60 minutes and have someone's full attention. And I think there's great value, and that translates across both. I'm not sure what happened to my screen, so bear with me. Okay, can you see my screen? No.
No, can't.
Here we go. I'm back.
Yep, perfect.
Oh, no, it's gone again. Okay, so I have it. Sorry, I wanted to talk a little bit about empathy, and I guess working with older adults. I've never been an older adult myself, and I wondered how people might share their stories with me, but I found that I didn't need to be an older adult, because empathy is not about trying to link my experience to yours. It's about trying to see things from someone else's frame of reference. And the quote that I have lost there is from Harper Lee, How to Kill a Mockingbird. And Atticus Finch says, you never really know a person until you get into their skin, climb into their skin. And it's a bit graphic, but really empathy is about trying to see things from somebody else's perspective. And what I found to be useful in that sense, the modalities that I guess if I could call them modalities, I really felt narrative and reminiscence therapy was really useful in connecting with older adults. And when I was thinking about this, putting this presentation together, I thought narrative and reminiscence therapy is probably something I use more with older adults. But I think when connecting with somebody and applying empathy, we do use narrative and reminiscence therapy, because every person has a story to tell. And so to hear someone's story actually assists the counsellor in understanding their context and to see things from their perspective. In my work with younger people in the high school, we'd often use sort of a solution focus lens, and with the older adults we used a lot of strengths-based counselling alongside the narrative. So a question that I often asked was, how did you get through that time in your life? And more often than not, the response was, well, I don't know, we just got on with it. But then it was working out, well, how did you do that? And so it was using their narrative to connect them with their strengths. I am coming to you from New South Wales, and the older adults that I connected with were all from rural Victoria, some places that I've never heard of before, but thank you to Google Maps, I could go there and see them. I imagined there would be some challenges. There were some challenges here with telehealth, because not everything goes to plan. And I wondered if telehealth might dehumanize in some ways, because I wasn't meeting them face to face. But what I found actually was telehealth is a bit of an equalizer, because we're looking at each other now sort of eye to eye, and you don't know how tall I am, and so there was there was no power imbalance. We met each other eye to eye on the screen, or I would speak to somebody over the phone. And I, reflecting on that, I wondered what impact that had on the adults that had identified with their pain. I couldn't see them in that sense. I didn't know whether they had mobility issues unless they told me. So I wondered if that added to that connection. There was also, with telehealth and the connectivity issues, there was also a great pro, which is that COVID didn't interrupt our appointments. Now, I did a 6-month placement, and I think in that time, there were, I think, 4 or 5 lockdowns, the facility. So I was able to still connect with people via Zoom, which was great, or by phone. I found that with telehealth, there was an increased sense of anonymity. So that was a pro, and also a bit of a challenge at times, because I am not going to bump into anybody at Woolies, or to see them down at the cafe, or to pop in. I felt that there was less inhibition perhaps, and people would really share some of their deep pain. So while that created a real sense of connection, there was also, on the other side, there was some safety planning and things like that presented itself. And because I am in a different state, it meant that I had to have really good processes in terms of connecting with people when I needed to, where there was a risk of harm or concern. So it was things that I learned. I learned that a sense of humour is essential currency when working really with anybody, but especially in this with older adults. I learned a lot of Aussie colloquialisms that I didn't know before. I learned that people working in aged care facilities are some of the kindest and most patient of people, and building relationships with the staff was really integral, really, to the connections that I then had with the older adults that I worked with as well. I found, as Philip sort of alluded to as well, it is relationship building when you're counselling older adults, and self-care is really important. I think something that I learned along the way in holding stories with people is that when someone has experienced trauma, that can be a really heavy burden to carry for a long period of time. And Mark asked me how my work with students might change after working with older adults. And I remember sitting with an older adult and hearing his story of his childhood. And I thought, and asked him that question, connecting him to his strength. How did you get through that time? And who have you shared that story with? And where there wasn't a connection, or there wasn't a clear support, I felt that trauma had been carried. We know Dr. Bruce Perry, who wrote The Body Keeps the Score and has done a lot of work in the trauma space, talks about adverse childhood experiences being the greatest predictor for mental illness. And that was really something, when Mark asked me about the way my work has changed, I think it has sort of illustrated the impacts that unresolved trauma can have across the lifespan. I had on my Zoom that, my slideshow that I'm not sure what's happened to it, but I had a picture of my own nanny. And just as I pass it across, I thought about the impact that this placement has had on me, and just the gratitude, I suppose, I have for having had this experience, the things that I've learned in my professional development, but also personally, I could see the impact that narrative and reminiscence therapy had in the people that I spoke with. And I found this book at Target called My Grandmother's Story or something like that. And I picked it up, and I don't know if you've seen it, but it's each page has a different question for a different, it's sort of broken up into chapters of life, and it is narrative therapy, really. And so I've started weekly Zoom calls with my own nanny who lives in London, and I got her permission to share the photo, but she said, I don't mind, but couldn't you find a better photo? And so, sorry, Nanny, I did use the photo, but no one got to see it anyway. But I found really in closing, I think, as Phil has highlighted and Mark as well, empathy and relationship building is really key here. There were some challenges for me in sitting with someone else's pain, and I guess contrasting when working with teenagers, there's safety planning and support and solution focused and things like that. But as Phil and Mark have pointed to, that we really had the privilege of sitting with someone's pain really in the final chapters, and our role is not to fix, but to hold. So I'm really sorry about my PowerPoint, but thank you for staying with me.
Oh, Sam, look, that's beautiful. We can picture your aunt. You don't have to describe it. I can see her in the way you described it. And what a beautiful example of empathy I can hear in your voice, and knowing you, it is the key. And you were sitting with people, and I know that's in a similar vein what Philip's doing, just sitting with people, acknowledging their existence, making them feel special. And thanks for generalizing this work, because I think, it has lots of crossovers with young people. And I think you are changed. I know, because we talked, all of us are changed by the experience that we have. And, one of the definitions of counselling is that you need to be prepared to be changed by the experience of meeting someone across from you. And I think you are a good example of that. So, Sam, thank you very, very much for sharing your work. And I'm sorry about the technology. This is, again, what telehealth is all about. But we'll make it available. It's not lost. We'll make it available to everybody with the recording. We'll have all the PowerPoints together. So let me introduce Deb. Deb Carver is a counsellor and group facilitator who's worked to support the emotional wellbeing of older adults, both in residential care and also in inpatient settings. And her work is underpinned by the belief that everyone has the right to feel relevant and heard at any stage of their life, irrespective of their age. And working with groups can feel a daunting step to take as a student counsellor. I remember, Deb, when you first started. In this presentation, Deb's going to share the story of her experience co-facilitating a reminiscence group for 9 months during her placement with Swinburne, and also some of the things that she learned and realised along the way, which have enriched her practice and which she hopes will be helpful to anyone who's thinking about group work. So over to you, Deb, and I will share your PowerPoint in a minute. Do you want to start talking, and I will share screen?
Hello, everyone. It's good to be with you this Friday afternoon. I've had some technological issues, so Mark's kindly agreed to drive my slides for me. So when I was thinking what to sort of title my presentation, I decided working with groups, yes, fine, but it was the journey from no way to where I'm at today that I really wanted to share with you. So yeah, next slide, thanks Mark. So I'd also like to acknowledge the traditional custodians of the lands on which we meet. I'm on the lands of the Bunurong people of the Kulin Nation, and I'd like to pay my respect to elders past, present and emerging, and to any Aboriginal and Torres Strait Islander people here today. So yes, a quick bit of a background. This is like a very whiz-bang overview of my final year. So in 2021, I completed my third year placement with the Swinburne Wellbeing Clinic for older adults. And I'll come to those next two little points in a minute. So I graduated, I think, early last year, 2022, from the Swinburne Master of Counselling course. And then in late 2022, I began a paid role as a therapist, and I'm currently working with groups of older adult inpatients in a private hospital. So there were two things that happened. I went into the placement really excited to have the opportunity to work in what I thought would be like a one-to-one situation. And very early on in a meeting with Mark, who's also my supervisor, he asked if I'd ever thought of doing group work, and my brain just said, no, no way, you can't do group work, that's far too daunting. But Mark's got a quite magic, persuasive way with him, and by the time that session finished, I said I'd give it a go. And it turned out to be a really transformative point of my placement for me. So what I wanted to sort of share with you all today was just the message that whilst you're on placement, just give things a go. If you get an opportunity, give it a whirl. And if you do undertake group work, just play to your own strengths, get stuck in. It's such a great way to build skills which are transferable, and you're working in a totally supportive environment. The regional aged care facilities are so glad to have the input, and you can practice your existing strengths, and you can also discover new ones. And this is another line I've coined from Mark. There's just hold in mind at all points that there's a very thin line between magic and disaster. So a brief overview of the kind of groups I ran. It was the height of the COVID lockdowns. We were working in PPE. It was quite hard going. And singing group, I should stress straight off the back of that, wasn't something that we ran at that point. We sort of came to it later on. So in the middle of all of the lockdowns, we were attempting art groups. They were pretty hard going. They were quite short-lived, but I think that was to do with the cohort of older adults I was working with. There was some beautiful transformational points with that art group. But the real standout for me was the reminiscence group. And following on from what Sam was just saying, it's just got this magic transformational quality. It builds connections. It helps people to just take a pride in a connection with their former life, which I think a lot of people lose when they move into aged care. So a little bit about goal setting and things to hold in mind when working with groups or planning to work with groups. And I borrowed a lot of this from Yolom, and I don't know if you can see, but I'm holding up this Bible, The Theory and Practice of Group Psychotherapy by Yolom and Molin Lesh. I don't know how to say his surname, I'm really sorry. Mark, do you know how to pronounce that surname?
No, but I'm sure Pete doesn't matter. People will know it.
So it's about creating a safe, welcoming environment that's free from judgment. It's about building belonging and connection. And there's facilitators looking for parallels and commonality between the people who are participants in your group, so that you can, it sort of takes the work out. Oops.
Sorry.
Extend the power of the work beyond the group in that way. Reconnect the participants with their pasts, embed them in their current community and reconnect them with themselves, as I was saying, and instill hope for the future. I think that's really key, and work to bring their past experiences into the present day. So those are all just things to sort of hold in mind, I think, when you're working in aged care facilities and with older adults. Thanks, Mark. So some of the things that I felt that I learned in placement, which has transferred into my group work now, is just the understanding of the dynamics, literally the orchestration of working with a group of people and all of the different personalities that you encounter, the different presentations, where people are at in their own particular journey. You know, you've sort of got to bring the quiet ones up, and you've got to sort of find ways to manage the more verbal people. There'll always be somebody in every group that talks a lot, and those people are fantastic because they really encourage participation from other people, but you've got to kind of manage that dynamic. The importance of establishing and upholding group guidelines, revisiting things like confidentiality, which can be tricky in working with groups. The importance of being flexible was something that I can't emphasize enough, not being precious about sticking to a plan. You can spend so much time and energy in devising content for your group, and then walk in, and depending on the day, depending on the mood, it'll either fall flat or you'll find yourself going off on a completely different tangent, and that's absolutely fine. Remember that you're there to facilitate, and whatever materializes between that group of people, it's about the connection between them. The need to speak clearly and slowly when you're working with older adults to allow for any cognitive or hearing impairment. Dealing with interruptions, no matter the setting, particularly in aged care, there'll be people coming in and out all of the time, you know, to give people medication, and you've got to roll with that. And keep in mind that some days will feel super hard when you're working with groups, and other days will be super rewarding. Yeah. Next slide, thanks, Mark. So, oh, I can't see my little.
Sorry.
Oh, sorry, that's on my screen, isn't it? So getting work ready. So it was so valuable to have the experience to have a crack at group work during placement. It taught me the value of working within a multidisciplinary team and feeding back and collaborating with other, you know, other people from other backgrounds, like the nursing team, the care team. The experience of reflective practice is something I really value, and it's a great thing. I cycle to work and I cycle back from work, and it's a great opportunity to reflect on what might have gone better, or if you feel like you've had a bad day, what you might do differently next time, or to celebrate what's gone well and remember ways to embed that into delivery of future groups. I had the opportunity to co-facilitate the reminiscence group with another student who was doing the same course as me, Miller. That was really invaluable. You learn an awful lot about yourself and about your own strengths and weaknesses when you're co-facilitating with somebody else. And I really developed an appreciation of the benefits of working with a range of tools in a therapeutically informed way. So like I was talking about earlier, there's the art and the craft. There's music, and as others have said before me this afternoon, just bringing all of those things in. It's about the way that you use them. And also writing progress notes, like getting into the hang of that on placement was really, really useful in transferring into the workplace. Building resources, when you're working with groups, I think everywhere I go, I've got my eye open for things, whether it's gum nuts, whether it's books like Sam was talking about, you know, you're sort of like be in a bookshop and a book will catch your eye. You're just constantly building your resources. And I've just put a couple there. The Kota reminiscing story cards are fantastic. And so are the happiness trap, the values, goals and barriers cards. So that's a very broad brushstroke overview of my experience. And what I just really want to share with you all is just to encourage you to have a go. This is such a safe, supportive environment. And yeah, who knows where it'll lead you.
Oh, look, thanks a lot, Deb. That's lovely for people who were involved in group work. We're running out of time, but I'm going to introduce Talia. She had a pre-recorded session, and I'll play most of it. But as I said, we're going to be able to have all this, all the extra resources actually on the website. So with the recording. So just let me introduce Talia, who is a provisional psychologist who's doing her master's. She just finished, I think, her work a couple of days ago. She's several years of experience and skilled in the context of disability support, especially mental health and wellbeing. She has experience as an academic advising and with specialised wellbeing case management in higher education. She's currently completing her placement at Swinburne, and she also co-facilitated a carers support group. We still have vacancies, actually, and we can put in a chat a flyer for that group if anyone's interested. It's starting fairly soon, and there's still a bit of room for that. And that's something that I think is badly needed. And she'll talk about the group, her work in our research program. I'll just play her once I share screen. Where is it? That's it. And I hope you can hear that. Why can't you hear that? Oh, because I've got it. Oh, that's why.
So yeah, as Mark said,
Hang on, I'll play it again.
So
look, sorry.
I
guess the first question is, Talia, can you tell us a little bit about you and about the placement you've been doing with the Wellbeing Clinic? And, you know, it's been mainly in residential care. So tell us a bit about that, Talia.
Hi everyone, I'm Talia Vesio and I'm a provisional psychologist, and I'm currently completing my Masters of Applied Psychology, Clinical Psychology with Victoria University. So yeah, as Mark said, I started with the ELATE program through the Swinburne Wellbeing Clinic of Older Adults in October last year. And so the ELATE program is the Elders at Ease program, which is a 16-week CBT research program as well as therapeutic program that's run within an aged care facility. In my final year of my course, and that I was has just finished last week working with that 4 clients in that 16-week program, as well as doing some telehealth through triaging intake clients, as well as a group program, which we'll talk about a little bit later.
Now, you mentioned ELATE, the Elders at Ease program, which is our research program. Can you tell us a bit about that research work? And also, you know, it contains a manual. So, you know, one of the hard things, isn't it, is how do you know how you balance this manual versus meeting the individual kind of client? And it's always a dilemma. And you pointed that out to me when we chatted. So tell us a bit about that.
So I guess one of the main things I notice, especially when working with a manualized programs that is CBT oriented, is that you do need to be mindful of your pace, especially with older adults. So some of the concepts and some of the, I guess, strategies and interventions may take you 3, 4, 5 sessions in comparison to perhaps in another setting where it might only take you 1 or 2. So just being aware of your pace and I guess not overloading the resident with psychoeducation and things like that within the one session can really help to kind of just get them to understand the basics first before transitioning to the the intervention or the strategy itself. And in terms of the research component, what's interesting and what really helps from the psychologist perspective is that at pre-starting the program, they are assessed to have done some baseline measures, which gives you a bit of an indication of where their problems may be lying or some of the difficulties they may be experiencing. And that can help in those initial sessions to kind of get more context around those. And then that is again completed at the midpoint of those 16 weeks and then subsequent after the 16 weeks. So you really get to see, how that person may be progressing, and I guess using that in combination with the therapeutic aspect.
I'm going to, because of time, I'm just going to play the last bit of reflection
for them, or building their confidence to do it themselves. So I think that's a truly rewarding experience in itself, that you've only got 16 weeks, but you can make a lot of impact in that time.
And a quick comment about the impact on you, Talia.
Yep. So it's truly rewarding. It's I don't think I'm ever going to forget this placement, because just spending time with the older adults, they make you, I guess, reinvigorated with life again, because they're like, you've got to live your life when you're young. Things get more challenging as you get older with health ailments and things like that. So I think that really just reiterated for me that you've got to live your life. And whatever that looks like, just, sometimes when you're studying and you're working and all of these things, sometimes it just feels like you're in this little cave, and it's hard to, remind yourself that you're full of life, and you've got to really go out there and do fun things that make you feel good all the time. And I guess, keep active, like the things we're teaching them, we've got to still do for ourselves too.
So I'll stop there. Oh dear, hang on. Sunil, if you could take over and sum up, that would be terrific. And I'll go on mute. Thanks, and just remember that everything will be available on the website. And if you could have the questions, we're going to be able to answer the questions, also on the website. So over to you, Sunil.
Thank you, Mark, and thank you very much to all the speakers for sharing with us your perspectives. I've been listening to your reflections, and look, there are three themes that stand out for me. The first is the importance of being present and authentic in this sector. If you are yourself and you are invested and you are wanting to be helpful, it sounds like that is part of the process of connecting with older people, particularly those who might not be so aware of your professional credentials or even the value that you bring to your counseling. So that's a really good take-home message, I think, for all of us. Second theme is to be prepared to perhaps walk a little bit outside of your comfort zone and to be open to new experiences and maybe even new ways of working, and to challenge perhaps some of the restrictions that you've imposed on yourself. And the third, very interestingly, is not to be afraid to bring in your awareness and knowledge from other areas of counseling into the aged care world. We heard about some of the connections that people are making to other areas of their work and even to their own personal life. So what a great reminder that maybe we have the competency and the skill sets already, and it's just about applying it to this sector. So on that note, I do want to thank all of you for joining us this afternoon to view the webinar with us. As Mark said, we will have this webinar available for you to watch as well. And if you do have any questions, please do send your questions on the chat, and we will make sure that we respond to them when we post the video. So on that note, I wish you all the best. A big thanks to our presenters, and hope to see you again. Thank you.
Thanks, Sunil, and thanks everybody. And apologies for the technical issues, but it's a wonderful job from all the panelists. Thank you.